Hi, I'm Dr. PhillipMcMulen. Thank you for joining me. I'm talking today about a really important observation, and this is coming from anonymous whistleblower. But listen to the background first. Now, I have been speaking with Thomas Haviland, who had done work on embalmers clots since about April of 2023. I'd previously glimpsed stories about died suddenly. Truthfully, I ignored it initially. But as the stories continued to come through and we started to see more and more clotting diseases, it made me think more carefully. And Thomas Haviland had reached out to me and said, this is important. So I listened. And his observations from just simple research, reaching out to embalmers, indicated at that point that a significant percentage of embalmers across the world were noticing abnormal clots. So we then had further discussions where I had a discussion with a pathologist, Dr. Shetty, an embalmer, and we discussed what he was observing. One of the things that I had said at that time was that I thought that this was a post-mortem occurrence, meaning that these clots were largely occurring after patients died. And it was still significant, but probably not as worrying as if they would be happening ante-mortem while patients were alive. And my theory was that if this was occurring ante-mortem, we would have heard about it. We'd have probably seen it on angiograms. Vascular surgeons would probably have noticed it and said something about it. And so for easily about 8 or 9 months, that has been my perception. And when I did my presentation on embalmers clots, I was looking at cryoglobulins as possibly the most likely mechanism with which this could occur. Now, what has now occurred is that someone has reached out to me as an anonymous whistleblower who works in a cath lab. And in case you don't quite understand, a cath lab is where they do the removal of clots in the living. And so if somebody has a clot on the lung or a clot in the leg or a clot in any artery or even a clot in the veins, they can reach in with specialized equipment and pull them out. At this point, I'll tell you, I intend to talk with this anonymous whistleblower, understand why they want to remain anonymous, and critically, to try and understand what could be the mechanisms around this. Now, before we start, we have to ask the question that if this is occurring ante-mortem, meaning that when patients are alive, the clots that the embalmers were seeing are so frightening that it would certainly be something that would have to be investigated. I cannot corroborate what this person is telling me because I'm not going to their workplace, but I will give anybody the opportunity to reflect on what he's saying. He's bringing images. So if you are squeamish, stop here because we will be looking at images as well. And when we go through that, my point is that we all have a responsibility to ask the question, if this is occurring, why don't people feel safe in order to try and speak about it? So without further ado, let me introduce you to my anonymous whistleblower. Hi, how are you?
Doing well. Thank you.
Excellent. Now, listen, you reached out to me with regards to what you have been observing. What made you, one, first start to speak about this at this point? What was the trigger for you?
My conscience.
Okay. And what does that mean?
It's been weighing on me for the past couple of years now.
Mm-hmm.
As I started to watch interviews with the embalmers, um, the common question had come up whether this is happening after death. And I was there with my team and the physicians pulling them out on a daily basis out of life patients.
And about how long have you been working in that environment? Is it just a few months, few years?
I have 20 years experience in the
20 years experience.
same lab. Yes, sir.
Wow. And so you have been working in this. And just generally, give us some general idea as to what kind of work does occurs in a lab like this.
We do cardio. We do angiograms of the entire body from head to toe, which means if someone comes in with a heart attack, we are what's called the STEMI team. We have a 30 minutes response time. If someone is bleeding internally, we do what's called embolizations. We do now, which is happening more than it should. We are now faced with this new clotting phenomenon, which means that is now emergent. When we get that phone call, we have 30 minutes to respond because that patient is what we call in critical condition where they cannot breathe. Basically, they're drowning from the inside out. And me and my team go in. There's a rep on site to help the physician, to guide them. We use devices like vacuums. They're very tiny that go inside the arteries and veins, and we suck them out.
And so this is a pattern you've been doing clearly for a long period of time. When, in your opinion, did you first start to see a transition in the types of clots you're seeing?
We've always seen what we call, or what people have called, jelly clots my whole career. But this new white clot issue, which I compare them to calamari or rubber bands, very strong rubber bands that cannot be pulled apart. This phenomenon has started in late 2021, and we have pictures as early 2022.
Yeah, we're going to go through those pictures in a little bit, so you can show me when I come across it which one was one of the first ones. But we'll come to that in a moment. But just trying to understand, are you the only person who notices this?
No, sir. I have my colleagues. We have about 20 on staff, nurses, anesthesiologists, vascular surgeons, radiologists, and cardiologists have all witnessed this.
And so what is the general response? Are people just surprised, but this is not relevant? What do you observe?
My position is to work hand in hand with the physicians. So I'm physically there, pulling them out of the patients. And I hear from time to time a physician will ask the room, what is that? Sort of shocked. We've had physicians send them to pathology. But from that point on, that is physician to physician record. And we don't hear what happens after that.
Now, somebody could quite easily say, well, you know what, this is just anecdotal observations. You find maybe you are sensitive to noticing this more. Maybe you are against stuff in the pandemic. Is this really that obvious, you think?
The clots themselves have changed, and anyone in my position, any other person that does the same type of work should recognize the difference.
Mm-hmm. And so, yeah, so you're saying that this is obvious. And may I ask, from your personal point of view, so that we are clear on this, what is your situation with regards to vaccine status? Are you happy to speak about that?
I'm one of only a couple percent at my hospital that has not taken any vaccines.
Mm-hmm. And so you haven't taken a vaccine. Well, just explain to us, because that could be considered anti-vax. Were you always anti-vax, or is this something specific around the COVID pandemic?
No, I have all my previous vaccines. This one was different. When my colleagues started to report to me about their reactions that they were having, tingling in the fingers, headaches, insomnia, menstrual cycle issues, I spoke with my family and they agreed that I was going to make the decision to stand firm on not getting it. I then was pressured from colleagues, doctors. I could remember a physician walking in the room and saying, "You're all going to go get this vaccine." And I just felt at that point that it was wrong. So I stood firm.
And so somehow in your circumstance, why didn't you lose your job?
I think that had to do with my position at the hospital, the needs of the hospital. Without me, the team loses someone very important. I have a lot of experience. I've trained many of my colleagues, nurses, PAs, technologists, and the physicians and staff, they depend on me.
Mm-hmm. Okay. So this is quite important when we think about that. So your situation at that time was that you were in an environment where you were unvaccinated. You then noticed, would it be reasonable to think that your sensitivity to seeing problems would be heightened? Would you consider yourself to be hypersensitive to looking out for complications around the pandemic and the COVID vaccine?
I didn't have to be. It was plain and clear, the changes that were happening with the blood, both arterial and venous.
This is quite significant. Now, you've therefore been seeing this for some time. Have you escalated that within the hospital to either management or any other whistleblowing mechanism? Any thoughts about what you would do around that?
When I was threatened, in a sense, to go get the vaccine, and if I did not, that has an effect on you. It hung over my head for about a year. I actually thought I was 100% going to lose my job. When that happens to you and they threaten that, and they threaten your livelihood to take a license even away, it changes the way that you will speak about anything in that environment. So I chose to just not say anything. But my conscience, it hangs over it. And I've talked to my cousin recently. He knows my story. And as the patients got younger and younger, it's made me now say, if I can help anyone, a child, someone on their way to college, someone being pressured because of a sport, a mother that is deciding maybe or whether or not to take a vaccine, if I can help just one of them, then my conscience is clear.
Those are powerful statements. And when you it makes me think, why are there so few people who seem to be willing to take a stand? Or maybe it's just time, because it takes time to make that kind of decision and to step out, because we're doing our best to keep you anonymous, but it's possible that somebody could recognize you, recognize your voice or something. Does that concern you?
At this point, it doesn't. It's life or death that we're talking about now. I know what's on the horizon. And so, no, that doesn't bother me anymore.
Yeah. No, we appreciate you coming out with this, because as soon as you reached out to me and I recognized the relevance of what could be occurring, in terms of meaning that I didn't believe this was ante-mortem. I thought to myself, if this was occurring, we would know. I find it frightening that we don't know, And so what I'm going to do is I'm just going to show a few pictures here, just so that people can see a little bit about it. And you can explain what these images are. So what is this one here?
That is a clot that we have pulled out of the right common iliac artery.
Mm-hmm. And okay, so about how long ago was this?
This one was probably about 6 months ago.
And was this one of the very stretchy, rubbery-like clots?
Yes, sir.
Okay, and so it looks pretty red in terms of the appearance. So it looks like a typical clot, so to speak. But yes, I understand. I'm just going to try and see if I can pull up a few more images here. I've got another one here, and again, I warn people, if you're squeamish, please, step away at the moment, because we're looking at real clots. What is this one here?
That is a left lower leg extremity DVT blood clot. Mm-hmm. Mm-hmm. And the reason why they might appear normal, although this one doesn't, the last one did, it's pulled directly from the patient, which still is coated in blood.
Mm-hmm. And so in effect here, what are these images here on the left?
On the left, that is an angiogram, actually a venogram of the lower extremity.
So this is the clot in the vein at the time. And so where it's so where it's dark is where the contrast has been injected. Where it's light gray is where the clot is. And so this is extending all the way down into that lower leg. And about how long is this, do you think?
That one there is about 8 inches.
Yeah. Yeah, that is fascinating there. I tell you what, I've managed to get one of my favorite people here, Dr. Shetty. How is your signal now, Shankara?
I hope it's okay, Philip. Can you hear me?
Yes. Now, just to give you context, Shankara, what we've got here is an anonymous whistleblower. He's based somewhere in the US. We don't speak about where. He has over 20 years experience in cath labs. And he has started to see clots occurring since about 6 months, late 2021, that were abnormal looking, similar to what the embalmers were talking about. And if you remember when we had our discussion, Shankara, we had my question or my thought at the time is that this was not occurring ante-mortem. This was all post-mortem, which would change the pathology around it. But what he's saying is that in the cath lab, they are seeing extensive clots. And the one that I had here was a DVT, an extensive DVT. But are you saying that this did not occur before of this scale? Is it the size? Because we get DVTs all the time.
Yes. This has started in late 2021.
And these are quite exceptional. And just so anyone knows, this left lower extremity, DVT, and no TPA. That means they didn't give them any clot busting agent to try and break it up. So they pulled this out whole from the leg. So these are quite enormous clots. I know I'm just dropping you in, Shankar, but any
Yeah.
thoughts at the moment?
Philip, from the work done, I think with the Resia Pretoris here in South Africa, looking at the different types of proteases to try and break it up, they found that it's got a lot of fibrin in it, collagen in it. So it's not really a clot. It's not the traditional clot. The traditional anticoagulants don't break it up. So I think what we're dealing with is a sort of fibrinous, collagenous emboli that's forming in the vessel itself, and it's actually taking the shape of the vessel, something very unusual. So it's not actually a clot. It's a cast.
Yeah, that's a very good description. Here's another one here. Tell me what is this one here?
That has clot bilateral legs up to the vena cava above the renos.
Mm-hmm.
And that's
And
about
so,
that's about a foot and a half long.
yeah, so this is the inferior vena cava going down. These are the veins going down into the legs. This is where the kidneys are, about the midpoint of the abdomen. So this is clot all the way down on both sides. And this is what it looked like when they took it out of the patient?
Yes, sir.
Wow. Wow. Again, Shankar, any thoughts?
Oh, Philip, it looks, when we looked at this with initially with Mr. Hirschman, I think it was.
Yeah.
I was considering whether this is something to do with the hydrogel that's used. Hydrogels have been used as tissue glues, that kind of thing, for a long time. And I think we need to look at the research around hydrogels and how they interact with other things, because this is not natural. So it's got something to do with whatever either the nanotechnology that's being used or the hydrogels, the lipid nanotechnology. And I think somewhere there we're going to find the answer to this.
Yeah, but this is serious stuff. Here's another one here, another image here, and just tell us what this one is.
We call this a saddle PE, which is the super emergent cases that we race in for. This patient is basically maybe breathing through one windpipe. So even the slightest movement as we move the patient from gurney to our bed can knock one of these clots to that windpipe, and that patient would be at that point considered code blue, where we'd have a whole team rush in and we'd be working now extremely fast to save that patient's life.
Mm. So this in gray here is the clot. Again, bright white represents the contrast around it. And this is therefore what it looked like in all the vessels. Now, saddle PEs, I mean, they do occur, so it's not as if they don't occur. What about this would have made you concerned?
As far as what, can you repeat?
So was it just a bigger clot, or is it that you're seeing multiple saddle PEs, far more than you would normally?
Yes, we have a big increase on our numbers when it comes to saddle PE. We used to maybe get one every couple of months. Now we're getting a couple every week.
Wow.
Philip, have they noticed the difference in the consistency of the clot itself? That it's less, it's not as friable as a traditional clot. Does it have the elasticity of the things that we're seeing with the embalmers? Washing off to a white consistency.
That's a good. So recently, just only last week, we pulled out one of these clots, and I tried with all my force in front of the room. Everyone was kind of looking. I tried with a good amount of force to pull it apart, and I could not.
Mm-hmm.
Okay.
Yeah, yeah. So here's
And,
another. Mhm.
I
Go
think
ahead,
as well,
Shankar.
from experience from the cath lab, have you seen anything like this before?
No, sir.
Was there a point at which you started to notice this? Because it's typically, I would say, unusual.
As we go back on the pictures, we thought it was something that was just a fluke, something that just would go away. So no one really paid too much attention to it. This was in 2021. In 2022, as we started to increase on our numbers, we then started to question at that point the changes, the pathology. Even, like I said, these vascular surgeons are in the field for 30, 40 years. And for them to look across the room and look at the clot that they just pulled out and to ask the room, what is that? We started then to notice there was something wrong.
Wow. Would explain this one here.
This is also vena cava. It is a patient who presents also with a aneurysm, as you can see it drawn out there to the left, and then clot above that.
Mm-hmm. Okay, so the aneurysm is here.
Yes, and then that left side that kind of breaks off to the left, that is going into the kidney, the left kidney.
Okay. Yeah, okay. So this one here, left kidney, and then this is going down the vena cava.
That's correct.
Wow. Yeah, so I'm just stepping through some of the images here, Shankar, and getting some context. Any kind of link to a patient has been removed so that we can just objectively look at the images, because these are real images, and try and make sense of them. So here's another one that you've got here.
Yes, this is also right leg. Actually, no, I take that back. This is also PE. This is the right lobe, and those are the blood clots. And then to the left there is the actual device, that tube-looking thing that goes up into the lung, the right lung, is a suction device, somewhat like a vacuum that we then suck the clot out to save their life.
Yeah, and these clots here, so we can see what look like grape jelly, the typical grape jelly. Would this have had the abnormal consistency as well in these whitish parts?
Yes, you can see the change, the transition there. You see the jelly clot on that lower part there. That's what we always seen. But as it changes, as it turns white, that's where you got those fibers like material that is now embedded in the clot.
Yeah, I find it very concerning, Shankar, that this is occurring ante-mortem. And how can we not be seeing it on angiograms, general routine angiograms? Because angiograms are done all the time. Any thoughts?
Philip, I'm not sure how that works, because the angiogram should pick it up easily. It's an obstruction to flow.
Well, what I mean is that maybe we're seeing them earlier.
I think Dr. Shetty was right when he said it is a casting. So on angiogram, it's somewhat easy to only see a possible narrowing as the contrast still material is running on the inner. So I believe that the fibers can be mistaken for the actual material, just like a vessel wall.
Yes, because it's smooth. So when you look at the white fibrous thing, it's smooth on the inside. So it almost lays along the artery.
Yes.
As quite right, as you said, Shankar, as a cast. So I'm trying to think about what would cause it to do that. I just can't think of a replica disease.
You got a couple of things at play, Philip. You've got the endothelial damage, so depending on where that occurs, where the offense occurs in the vasculature, that combined with this technology that's around creates a reaction. And so that might be the reason we're seeing it in such diverse areas. I'd wonder whether the same patient would have it in different areas, or whether each patient develops it in a unique area depending on the type of administration of the vaccine.
I guess the thing that I'm the thing I'm trying to work out, Shankar. So if you imagine, we have this in plaque disease. So where you have the endothelial damage, you then have the plaque deposited. But if this is more like a cast, it seems to then grow and extend down the blood vessel, which a plaque doesn't really do. It tends to concentrate where the damage is. And so this is very, very unusual. And I can't think of a replica disease where we would see anything like this. So this is where you have to then step back and say, is this about the technology rather than anything else?
Yeah, I think as well, if you look at the way it's pulled out, you've got a cast of a vessel, very strong structural cast of a vessel that you can't break up. But it's not attached to the vessel wall. You can pull it out. So an injury, generally with scarring and that kind of thing, will attach it to the vessel wall. So there's some other mechanism at play that.
Yeah. And so tell me again, what is, sorry, let me get this here. What is this one here? What was it about this that made you look at that one?
If you were to zoom into that, where the white begins, it's a lot tougher than what it looks. That white webbing, it looks like a webbing. And that's where I think that's why that casting is such a great description. So what happens is if the vacuum device doesn't work, we use a basket. Okay, you got to think of it like a rake. It's a basket that we go up past the clot. We open up the basket and it scrapes along the vessel walls. So we are able to then pull out the stuff that is stuck to the walls, that is, I believe, which is growing onto the vessel walls, both arterial and venous.
Well, yeah, I genuinely, I'm not quite sure what to say, Shankar. So Shankar, what he has been mentioning is that people are noticing this, but there is no safety with talking about it. So let's ask the elephant in the room question. Have you noticed, or did you look at any question about vaccination status?
Yes. So I guess there's some that can say that this is caused by COVID itself. There's people that say that it can be in the unvaccinated and vaccinated. But I know the patients, they're my patients, and I have to access their chart. And when I do, I know how many vaccines they had, when they got the vaccine, what type of vaccine. And it seems like the more vaccines that they have, the bigger the problem is. We've have patients now that have up to 8 vaccines. 8. But we also have patients with 1.
So what percentage do you think of the cases like this? But you have to be careful now because you are highlighting the worst cases. But even so, is there any kind of percentage you can imagine, vaccinated versus unvaccinated?
Well, I can only speak to my lab. And in my lab, it's 99% vaccinated.
And is this for all clots or just these big clots?
I'm speaking about the white fibrous clots.
Okay, so whenever you see a white fibrous clot that looks abnormal, the stretchy type, and then how often would you see that? 1 a week, 1 a month? And even that, what percentage of cases tend to have these white fibrous clots?
Oh, it's a big problem now. We seem to be only treating the white fibrous clots now because I think what has happened is that the doctors are racing to treat with heparin, TPA, and as they do that now, because right when they hear blood clot of any sorts, they will treat immediately. And when they treat them with the heparin and other blood thinning drugs, the normal clots dissolve immediately, I believe, and those patients don't have to come to us. The white fibrous clots is the majority, and we are now seeing about anywhere from 3 to 10 a week.
Wow. In the white, and in those patients, so what you are saying is that in the cohort of patients who have white fibrous clots, 99% are vaccinated?
Yes, sir.
Philip, it's you have to start somewhere. I think it's partly the technology needs to be looked at, because clearly it's partly the technology causing the problem. We know about messenger RNA and how it transcribes into proteins and how they work. This is unusual. We can't find our way back to that. This is the body depositing something on itself. And so got to understand how I think the technology used in the vaccines are actually triggering this issue. I think that's the most important place to look. And I think the second place to look at is what kind of cohort are we dealing with that develop this kind of clots? Is it specific to a specific cohort of people? And I did mention the genetic predispositions I've seen through the pandemic. And so maybe a place to start would be to look at the blood groups of all these patients presenting with these kind of phenomena. And we might find that it's limited to a certain blood group or a certain blood type or a certain type of, underlying predisposition. I think we have to start there. And that will give us some understanding of how they're forming and why they're forming, because it's some sort of, remember, this is some sort of blood constituent that is coagulating into a cast.
We also...
Go ahead.
One other thing that I've come to realize, and what we're all noticing, is that we put in what's called portacath into patients who are scheduled to receive chemotherapy. And what I've noticed over this past year is that cancer is not only on the rise, but we've had younger and younger and younger patients on our table.
Mm-hmm.
Have you noticed the younger patients presenting with late-stage cancers with metastasis?
Yes, sir.
Okay.
Mm-hmm.
So the speed is there.
So Shankara, what I want to do is just think a minute, because this is very important. This is the first time I've clearly heard somebody speak to this extent. And as I had said at the beginning, I can't corroborate it in the sense that I'm not going to go and look at whatever. I just want to imagine, how can somebody justify not investigating this if they have watched this? Is there any reason that clinicians, physicians would say, listen, this is irrelevant?
I think there's many things at play, Philip, from bribery and corruption we've seen through the pandemic to individuals recommending the vaccine and not being able to realize the mistakes being made. Whatever the case might be, we've got injured people around us, and we've got to find a way forward, from that. So if it's there, yes, I must appreciate those that are willing to, speak out and direct us. There are those of us who see it, and people watch and listen. So we got to enlighten those who wish to be enlightened, I guess.
I'm just saying, I just can't grasp if somebody sees this, because people will see this, what skepticism can, doctors can be very skeptical, and they can say, oh, this is, so on, and so this doesn't happen. I just genuinely can't see how, especially with the description of the fibrous clots happening ante-mortem, I can't see a logical reason other than ideology that people would be skeptical. They have to go and say, okay, let's check our labs. Let's look at our facilities. Let's see if this is actually true and the extent to which it's occurring. I can't think of any other logical response.
I think, Philip, as it gets closer and closer to home, you have to acknowledge. Like the vaccine injuries, more and more people know of other people that were injured by the vaccine, and so suddenly start to realize that the injuries are actually real, And it's the same with all the new pathologies we see. As the relevant specialists see it more and more, they start to realize that it wasn't just a slight increase or a blip in the radar. It's persistent and constantly increasing. And I guess that's when we'll all put our heads together to figure it out.
Yeah, I know that our whistleblower will have to leave soon, but I wanted to show here. This is another one here. What made you pick this up?
That is more unusual clot that we sucked out with a penumbra device, the vacuum. We put it over that 4x4 so that the blood could seep through and we can get a better view at the blood clot.
And this is more like the coffee ground that the embalmers are seeing.
Yes, sir.
Mm-hmm.
One other thing that we've noticed that cardiologists are noticing everywhere, and I can promise you that it's everywhere. I have colleagues in many different hospitals that I've got to know over the years as we ask from favors from one another, from lab to lab. We're noticing SVT. We're noticing changes in heart rhythms. I work with cardiologists who go inside with catheters to cauterize the inside of the heart to try to get those rhythms back to normal.
Mm. Yeah.
And these patients, we've had them as young as 13.
Wow. Well, let me show you another one here. I think this is one of your earliest ones. Is that right?
Yes, this picture is from, I believe, March 2022. And again, that's penumbra. We used a vacuum device to remove this clot, and that was the earliest picture that...
and this, again, is the white fibrous bit.
Yes, sir.
Mm. And where was this from?
I believe this is out of the arterial system. Penumbra we use arterially, and Inari, the other company, we use for the venous system.
Yeah. Whoa. Yeah. There's very little to say. Go ahead, Shankar.
Now, Philip, just to be clear, the clots that we're seeing, the shape of them, are they relatively firm, or is it where that the traditional thrombus exists, it's friable, or is it firm throughout with the thrombus covering it, more in some places than others?
Yes, the texture. 1 second, please.
Yeah, this is some complex stuff, Shankar. As I said, what shocked me was this was happening ante-mortem, as opposed to post-mortem. Post-mortem, I was going along with cryoglobins. If this is happening ante-mortem, this is something completely different and extremely worrying, because it is going to be occurring in people without any symptoms, oftentimes, until or unless it breaks up.
Can you repeat the question? I'm back.
Go ahead, Shankar. What was the question?
The clots itself, the consistency of the clots, does it have that firm consistency throughout, or are the areas where there's thrombus friable like a traditional thrombus would be? Or is it that the casting is intermingled with clot, but the cast extends the entire length of the clot itself? So the clot has a tough texture to it throughout.
From from patient to patient, that differs. There are
Okay.
some that are just smaller white fibrous clots mixed with the traditional blood clot. And then there's some that we pull out that could be as long as 2 feet, white clot all the way through.
Okay.
Wow. Listen, I mean, this has been eye-opening. I know you're going to have to run, and we appreciate so much you coming out and standing up to share this kind of information. My responsibility here is to then take this information and to put it out there with the hope that physicians and clinicians across the world, I don't mind if they refute it, because if this is occurring, we absolutely need to know. If it's not occurring, then we also need to know it from every angle. We just need to be investigating it. It is completely inappropriate that the embalmers have been observing this pattern, and it has largely been ignored. And so we really, really appreciate you being with us. And what I'll do is I'll let you go, and I will then continue closing out with a chat with Shankara. But any final words you'd want to say?
Like I mentioned previously, earlier on, I'm only doing this because it's been weighing down on me. I do this for that family who's on the fence. I do this for that child who wants to play a sport. I do this for the young man or young lady who is on their way to college, who is on the fence whether to take these injections. And if I can help just one of them, like I said earlier, then I've done my job.
Yeah. Well, we appreciate it. You've certainly enlightened me, and I'll go back to the drawing board to look at what the pathology could be. Thank you very, very much. We appreciate you speaking up, and I'll try my best to raise the awareness of this and hopefully get the medical community to, they either have to refute it or look into it. And the only way they can refute it is if they look into it. I don't think anything else is acceptable after what you have demonstrated, because if this is occurring ante-mortem while patients are alive, there is a responsibility on the system to investigate it. Thank you very much. Really appreciate your time and the images that you've shared with us that have remained anonymous, but gives us an idea as to what it is that you are seeing and has been concerning you. Thank you very much.
Thank you very much for your time.
Thank you.
Yes, Shankara. Yeah, this is some serious stuff. What do we say to our colleagues, the community?
Philip, I think we need to be rational at the least. We're seeing the problems with the technology. Okay, let's not even get into whether the vaccine worked or didn't work or the rest. The platform that they're using, lipid nanotechnology, is causing problems. We know it's not designed for this kind of thing. We know that trying to coax the body into making a foreign protein is not a good idea. But for some reason, this is looked at by some sectors of the scientific community as our new savior. And irrespective of the harms it's been doing, it's being translated into other areas of science like veterinary science. A lot of the animal vaccines are becoming messenger RNA based. They're trying to change all the traditional vaccines that we've used all these years with relative understanding of their safety and risks. Now are going to be changed to messenger RNA technology, even though we've seen the problems with it. So there's I think more a financial incentive rather than a true scientific endeavor for the betterment of humanity. And I think we need to look at that. The messenger RNA technology has its problems. We need to acknowledge that and rationally stop it right now and look back to see where we've made the mistakes.
Where do
But
we...
of course, I hear there's a law passed in France that if you talk against messenger RNA, they stick you in jail for a little while. So it seems like it is the new savior, and any talk against it is blasphemous. So I'm sure, the censorship's coming.
Yeah. So, I mean, as we said, so what can we say to our clinical, at the end of the day, forget the politicians, forget even the academic scientists, clinicians overall tend to genuinely be concerned about their patients.
Yeah.
What
I would say, stand up and speak to your patients about the risks of this technology and ask them to avoid it. They'll listen to you.
No, I'm talking about specifically the investigation on this, because it needs to be corroborated. What is their responsibility to their patient?
Look, Philip, I think it's to look. And when you see these things that are unusual, to report it. You can't sit on the fence with it. You see, I think a big problem is not the reporting of it, Philip, but the hiding of it. Physicians see it and just don't want to believe it. And eventually it becomes something that, we're going to normalize it.
Yeah, gosh. So yes, thank you as well, Shankara. This has been fascinating. I appreciate the extra thought and the extra eyes on this. I'll share this as sensitively as I can, but the aim is to force as best as I can as a single voice to ask the community, the scientific, the medical community, that we don't have the luxury of missing this if it is occurring. It is not a minor thing. It is a major thing. And we need to figure out what the mechanism could be. So there is a responsibility. I don't want anyone to say, I didn't know this was occurring. That's my job now, is to share this and say, you all know it could be occurring. Please investigate it. If you don't investigate it, as far as I'm concerned, that borders on medical negligence. We have to look at this.
And I think, Philip, the simplicity with an initiation of an investigation, we don't need to do the hard science straight up. We just need to figure out which cohort of the population is being affected. That would start with at least looking at the number of vaccines and what kind of vaccine caused the problem. What was the branding of the vaccine? And we'll find certain differences there. And then looking at simple things like blood groups, ethnicities, things like that, will lead us in a direction. And at least from that starting, we'll understand where to look. So it's quite simple to collect the relevant data that we need to start the journey.
Great. Thank you very much, Shankar. I'll just ask you to hang on with me for a few minutes. And for those who are listening, we continue to uncover, we continue to research, we continue to look for answers, because it is relevant to patients, and that is our responsibility. Have a great evening.